Some considerations. So parts don't fit. You go to do your placement and you're trying your guide on and you're noticing it's not going down at all. Something is tight. You gotta make sure that nothing is in the way. And what can get in the way? It's either tissue or teeth, or the guide itself might be a little bit too tight. The first two things are things you can look at and they're reversible. For example, you can see if you're getting held up on tissue or teeth without messing with your guides, because once you mess with your guides and you open up the interior of it, then it gets too loose. There's no getting the tightness back. So first we got to make sure that we're inserting it in the right path of draw, and that basically, you know, our flap isn't getting in the way, things like that. Once you clip the guide in, let's just say tissue and teeth are fine, is just our guide printed a little bit too tight. So we usually have, when we do the surgery, a barrel diamond right next to us. When we're trying the guide on and we make sure nothing else is at fault, you can take it out. In the inner proximals, you'll have teeth and you'll have little connectors that go interproximally between teeth. Those are the main culprit of making the guides too tight. So whenever I notice that, hey, I gotta really press on this patient's head to get this guide on, and if it snaps into place and I can't get it off again, it's going to be a problem, because, you know, there's been 1 or 2 times where we had to drill the guides off. So the first thing I do is we zip the interproximals out, and that makes it for a more passive seating of this guide. Another aspect of this, the guides aren't always too tight, they can be too loose. Say you've opened it up too much. You're putting this guide on, you're placing a guided implant bridge. You're really looking for parallelism, really accurate implant placements. You really want to make sure that when you're putting these multiple drills into your guide tube, nothing is shifting around, nothing is causing deflection. So if your guide is too loose, I mean, you can always print another guide and make the patient wait, but we all have really busy schedules. So what I like to do is, I like to have my assistant hold the guide, have 2 fingers on either side of the extensions, and at least when I'm doing the osteotomy, apply moderate pressure to the guide, the incisal edge of the guide. So another way to do it is you can even make a paddle connector, and I've seen that done actually today. So Dr. D brought over his guides, so I don't know if you guys played around with them. He made them out of the Sprint Ray splint resin, the flexible resin. It's a pretty cool concept. He has them with him right there. Once you get the guide on and you make sure it's not too loose, not too tight, and you're able to kind of alleviate both those factors, the other thing that happens all the time is that when you're going to do your osteotomy, sometimes the drill, for example, you try it outside the mouth, you run your implant motor through it, everything fits. For some reason you put it on the teeth, and then you put either your flat drill on or your sequence of guided drills, and you cannot hop it down all the way. So something's preventing your drill from seating all the way through the guide tube. So you know for a fact it's not the tube's fault, because outside the mouth you ran the drill through the tube and everything fits. So that's when you have to work the factors down. You're starting from the top, you know that, hey, it's not my guide. It's something below the guide. The number 1 culprit is the flapulae. If the flap gets in the way, and everyone here has seen these direct cut drills, right? The full guided keyless system, it's got a metal cylinder. The metal cylinder has a taper, and from the taper, that's where your actual drill comes out from. If your tissue is laying there, the cutting portion of the drill can get past the tissue, but the flat portion that guides it, it can get caught in the tissue, and no matter how hard you press, it's not a cutting section. It's going to get held up there, and for some reason you cannot press it down. So always take your mirror, always look inside the tube to make sure nothing's in the way on both sides of it, and you can see the bone that you're going to be placing your implant into fully circumferentially around. Next consideration, we went over this a little bit before. So the guided system, as we know, the key measurements, 8.5 millimeters by 5 millimeters. The 5 millimeter diameter, as you can imagine, has some drawbacks, because especially when we're working in the molar areas, sometimes we need a wider implant. So if the implant doesn't go through the guide tube, how can I make my surgery fully guided? So a workaround is, once you finish your osteotomy, you go to a 5mm, for example, you pop your guide off, you put the driver onto the implant. Say you're placing, a 6x10, and you made your osteotomy to a 5x10. You wanna downsize a little bit. You pop the guide off, you place the implant there by hand. Then over the top of your driver, you insert the guide so that your implant is still guided, but you're not putting the actual implant body through the guide tube. It's kind of like a backwards way of thinking about it. So place the implant in osteotomy, snap the guide over it, then insert your driver through the guide tube. That's one way to go about alleviating those wider implants that we like to use sometimes.